So we had two sets of outcomes. The first was it feasible to incorporate this pathway within standard NHS practice? And we set ourselves a target of 80% of the patients with suspected muscle-invasive bladder cancer randomised to an MR actually getting one. And in fact, almost all of the patients did. All but 2 patients got an MRI scan. So we comfortably hit the feasibility target, which meant we could then proceed to do the efficacy analysis. So for our efficacy, from pre-trial audits, we found that the typical time from the hematuria clinic to the definitive treatment, for example cystectomy, was around 100 days. And this is actually fairly typical of healthcare systems worldwide. It's not an NHS quirk. It's because you've got multiple stages in a pathway, you end up with multiple handovers. And our target was that we reduce that by a minimum of 30 days. So we expected we see 100 days time to muscle invasive on the control arm, and actually we saw 98 days, and that shortened to 51 days on the experimental arm. And then the key secondary outcome was that when we looked at all of the patients, so the patients who did not have muscle-invasive bladder cancer, which is 3/4 of the total in the trial, that we weren't adversely impacting their treatment time to treatment by prioritising one group over another. But in fact we did not. So the typical time to treatment was 23 days on the control arm, and it dropped to 21 days on the image-directed pathway. So there was something of a hint that putting the image-directed pathway was actually speeding the treatment for patients who were destined to get a TURBT, a transurethral resection, as their definitive treatment. MRI has been very disruptive to the management pathways in prostate cancer. So we've gone very much to imaging before we biopsy and biopsying targeted areas. And that's driven quite a big change in practice in terms of reducing over-treatment and over-biopsy, indeed, of patients with low-risk disease, whilst at the same time more accurately identifying patients with higher-risk disease. So the BladderPath trial attempts to do the same thing for bladder cancer, and I think we pretty convincingly show that an image-based pathway very much accelerates time to treatment for the patients at highest risk of death, those with muscle-invasive disease. We've got separate research which we've published previously, and some of it is based on this as well, showing that we can accurately profile the tumour DNA from the urine of bladder cancer patients. We don't need to do a large-scale resection to get a complete mutational profile of the tumour. So I think we're in a position where we should start thinking about restructuring the bladder cancer pathway to a biopsy, potentially profiling on liquid biomarkers in the urine, and using imaging to determine staging, which is pretty much what we do for most tumour sites, to be honest. And I think that will allow us to make more accurate treatment decisions quicker for the benefit of everybody, and reducing the morbidity of TURBT, which is quite an unpleasant procedure for patients to go through.